President of Doctors in Training, and our goal here at Doctors in Training is to help you be the best medical professional you can possibly be. Whether you're studying to be a physician assistant, or nurse practitioner, we feel like this pharmacology course is the right course for you. So I hope you enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome.
This lecture is on neurodegenerative diseases and drugs used to treat them. Specifically, we're talking about Parkinson's disease and Alzheimer's disease. Now, if you've been watching these lectures sequentially, you've just finished up a section on autonomic nervous system. And that's a pretty good place to start because the autonomic nervous system is very simple, relatively speaking. We're going to be talking now about diseases of the central nervous system, so we need to talk about the main differences between the CNS and the autonomic nervous system. The basic functioning of the central nervous system is very similar to the autonomic nervous system. You have neurotransmitters that diffuse across the synaptic cleft, bind to a receptor, and cause some type of intracellular change downstream. There are several major differences, though, between the central nervous system and the autonomic nervous system. Specifically, the circuitry in the central nervous system is much more complicated, much more complex. There are a lot more neurons involved in each connection. The CNS also has networks of what we call inhibitory neurons that are constantly modulating the rate of transmission. And then we have a lot more neurotransmitters involved. There are 10 to 50 different neurotransmitters in the central nervous system compared to just 2 neurotransmitters in the autonomic nervous system. So we need to talk a little bit about synaptic potentials. So in the central nervous system, most receptors are bound to or linked to some type of ion channel. And that can be an indirect link or a direct link. In some cases, you have the receptor that's actually part of an ion channel, so the neurotransmitter binds to that receptor and it opens or closes the ion channel. Then you have a lot of G protein linked receptors in which the receptor is linked to a G protein, and that G protein interacts with a voltage gated channel, or the G protein activates a second messenger that then modulates voltage gated channels. In any case, binding of transmitter to receptor results in rapid but transient opening of ion channels. These channels allow specific ions inside and outside the cell membrane to flow down their concentration gradient. These changes in ionic composition across cell membrane alter the postsynaptic potential, producing either depolarization or hyperpolarization of the postsynaptic membrane. The unstimulated cell potential is called the resting potential, and every neuron has a specific threshold potential. If there are enough depolarizing impulses, the potential will reach that threshold and an action potential will be generated. These depolarizing impulses are called excitatory postsynaptic potentials, or EPSPs. Neurotransmitters that cause EPSPs are called excitatory transmitters because they excite the neuron to fire. Excitatory impulses are generally caused by transient opening of sodium channels, allowing sodium to move down its concentration gradient into the cell, causing a transient depolarization. Generation of a nerve impulse typically requires activation of synaptic receptors by thousands of excitatory neurotransmitter molecules released from many nerve fibers. The resting potential is largely determined by the equilibrium potential of potassium. So, if a transmitter opens a potassium channel and potassium is able to leave the cell, the resting potential is stabilized and it becomes more difficult to depolarize the cell. Or if a transmitter opens a chloride channel, chloride moves down its concentration gradient into the cell, causing a small hyperpolarization. The neurotransmitters that cause stabilization or hyperpolarization are called inhibitory transmitters, and the impulses they produce are called inhibitory postsynaptic potentials, or IPSPs. If there is an inhibitory signal followed by an excitatory signal, the cell potential may not reach the threshold and no action potential is generated. So inhibitory transmitters inhibit the downstream neurons from firing. Most neurons in the central nervous system receive both excitatory and inhibitory input. There are several different types of neurotransmitters that can act on the same neuron, each binding to its own specific receptor. The rate of postsynaptic firing reflects the sum of all those inputs. Is the excitatory input predominating or is the inhibitory input predominating? Neurotransmitters can be classified as either excitatory or inhibitory, although it's really receptors, not the neurotransmitters, that determines this. Most neurotransmitters have several different types of receptors or several different classes of receptors. So a single neurotransmitter can have excitatory actions in some tissues and inhibitory action in other tissues. So the excitatory neurotransmitters include glutamate, which is an amino acid. It's the primary excitatory neurotransmitter in the CNS. There's acetylcholine, which is involved with arousal, memory, learning, and it's also involved at the neuromuscular junction, as you remember. A deficiency of acetylcholine is associated with Alzheimer's disease or Huntington's disease. Other excitatory neurotransmitters include norepinephrine, which is also involved with arousal and wakefulness, as well as mood and cardiovascular regulation. So if you have too much norepinephrine, you may have mania, and if you have a deficiency of norepinephrine, you may have depression. And as we'll see in a moment, depression is also involved with serotonin. And then there's a neurotransmitter called substance P. Substance P is a neuropeptide, and when I hear substance P, I think of pain. Substance P is an important excitatory neurotransmitter involved in pain modulation and pain sensation in the spinal cord. Then we'll talk about some inhibitory neurotransmitters. Remember, these are the ones that cause hyperpolarization. One of the most important inhibitory neurotransmitters is GABA, which is gamma aminobutyric acid. It's the primary inhibitory neurotransmitter in the brain. Then there's glycine, which is another amino acid neurotransmitter. It's the primary inhibitory neurotransmitter in the spinal cord. Then we mentioned serotonin briefly earlier. Serotonin has both inhibitory and excitatory actions. It's more predominantly an inhibitory neurotransmitter. It's involved in feeding, modulation of pain and nociception. It's involved in mood and emotion, and also wakefulness. So a deficiency of serotonin, as we mentioned, is involved with depression. You can remember that because the class of drugs called the selective serotonin reuptake inhibitors, or the SSRIs, including fluoxetine or Prozac, it's going to inhibit the reuptake of serotonin, so it's going to allow more serotonin to be active. So you treat depression by increasing serotonin because serotonin deficiency causes depression. The other inhibitory neurotransmitter to talk about is dopamine. Now, Lippincott mentions dopamine as an excitatory neurotransmitter. But dopamine does have some excitatory functions in some tissues, but it also has strong inhibitory functions in other tissues. And for Parkinson's disease, the pathways we'll be talking about today, dopamine is primarily an inhibitory neurotransmitter. So I want you to think about dopamine as inhibiting transmission in today's lecture. Dopamine is involved with emotion. It's involved with reward systems. So one of the reasons that cocaine is so addictive is it increases dopamine. And so it strongly acts on that reward system, so you feel good when you use cocaine. Excess dopamine is associated with psychosis. Dopamine is also involved with motor control, and so decreased dopamine, as we'll see shortly, causes Parkinson's disease. So let's talk about some specific neurodegenerative diseases. We're talking about Alzheimer's disease, Parkinson's disease, and amyotrophic lateral sclerosis. These diseases are characterized by progressive loss of selective neurons in discrete areas of the brain. In Parkinson's disease, we're talking about loss of dopamine transmission, dopaminergic neurons, in an area of the brain called the substantia nigra. In Alzheimer's disease, we're talking about loss of cholinergic neurons, or acetylcholine-producing neurons, in the area of the brain called the nucleus basalis of Meinert. And both of these diseases result in characteristic disorders of movement in terms of Parkinson's disease, or cognition in terms of Alzheimer's disease, and in some cases you get disorders of both cognition and movement. Alzheimer's disease is by far the most prevalent neurodegenerative disease. There are about 4 million people affected with Alzheimer's disease as of 2000, and it's expected that as our society ages, the number of cases of Alzheimer's disease is going to rise dramatically. We're going to talk first about Parkinson's disease because there are a lot of different drugs used to treat Parkinson's disease. As we'll see with Alzheimer's disease, there are a much smaller number of drugs we can choose from. So Parkinson's disease is a progressive neurological disorder of muscle movement. It's characterized by 4 symptoms. First, you have resting tremor. Sometimes we call that a pill rolling tremor. It's not just tremor when you're actively moving, it's even tremor at rest, and you'll see the hand kind of tremor like this as though you're rolling a pill in your hand. You also get what's called muscular rigidity, sometimes called cogwheel rigidity, where the patient's muscles will be rigid but not fixed. You can move them, but they sort of move as though you're turning a cogwheel. You can get bradykinesia, which is slowness in initiating movement or carrying out voluntary movement. You can also have gait abnormalities or posture abnormalities. Parkinson's disease is primarily a disease of the elderly. It's much more common in patients over 60. In fact, in patients over 60, the prevalence is about 1%. So about 1 out of every 100 patients you'll see who's over the age of 60 will have Parkinsonism in some form. When you get up to age 80, the prevalence increases to about 4%, so very common. The exact cause of Parkinson's disease is unknown for most patients, but the common factor is loss of dopaminergic neurons, destruction of dopaminergic neurons in the substantia nigra. And the substantia nigra sends these dopaminergic projections to the area of the brain called the neostriatum. So this is called the nigrostriatal tract, as we'll see in a moment, and you have decreased dopamine activity in the striatum. You can see loss of dopamine activity on a PET scan because there's loss of or a reduced uptake of dopamine in dopamine precursors in the substantia nigra. Genetics does not play a really strong role in Parkinsonism. This is not a purely genetic disease, as, say, Huntington's disease is, but it's thought that genetics may exert some influence on how susceptible an individual is to the disease. And a lot of people have what's called secondary Parkinsonism. So you can get Parkinsonian symptoms following viral encephalitis, following multiple small vascular lesions, or mini strokes they're sometimes called, sometimes head trauma. One of the most famous patients with Parkinson's disease is Muhammad Ali, who obviously in his career as a boxer had a lot of head injury, a lot of head trauma, and it's thought that that may play a role in increasing someone's risk of getting Parkinsonism. There are also a lot of drugs that will cause Parkinson's symptoms. Drugs like phenothiazines, such as chlorpromazine or the brand name Thorazine. It's an antipsychotic drug. Also promethazine or the brand name Phenergan, which is a common anti-nausea drug. There's a drug called haloperidol. All these can cause Parkinson's symptoms. Also, metoclopramide is a common drug for GI motility, and that can cause Parkinsonism or Parkinson-like symptoms. All these drugs have the common factor: they block dopamine receptors, and they can produce Parkinson's symptoms. So in a patient with Parkinsonism, you don't want to use any of these drugs if you can avoid it. To really understand how dopamine causes movement disorders, we need to review the basal ganglia. And just to review briefly, the basal ganglia include 4 areas: the subthalamic nucleus, the substantia nigra, the internal and external segments of the globus pallidus, and the neostriatum. And the neostriatum is made up of the caudate nucleus, which is involved in cognition, and then the putamen, which is involved in movement. There are 3 basic facts I want you to remember about the basal ganglia in relation to Parkinson's disease. First, the direct pathway facilitates movement, and the indirect pathway suppresses movement. Second, dopaminergic transmission from the substantia nigra to the neostriatum leads to more movement, regardless of whether you're looking at the direct pathway or the indirect pathway. And third, loss of dopaminergic neurons results in less movement. The substantia nigra pars compacta sends dopaminergic signals to the neostriatum via the nigrostriatal tract. This stimulates the GABA-producing cells of the direct pathway and inhibits the GABA-producing cells of the indirect pathway. The direct pathway projects directly to the internal segment of the globus pallidus. The indirect pathway inhibits the external segment of the globus pallidus, which inhibits the subthalamic nucleus, which in turn stimulates the internal segment of the globus pallidus. The internal segment of the globus pallidus inhibits the thalamus, which is responsible for sending excitatory signals to the motor cortex. Simple, right? Well, no. This isn't simple. It's extremely complicated. But let's try to make some sense of it by working backwards. The thalamus sends an excitatory signal to the cortex, which facilitates movement. The internal globus pallidus sends an inhibitory signal to the thalamus, which inhibits the thalamus. So the internal globus pallidus inhibits movement. The neostriatum modulates the internal globus pallidus in 2 ways. There's the direct pathway, in which neurons from the striatum directly synapse on the internal globus pallidus. This is the direct pathway. The direct pathway inhibits the internal globus pallidus, so there's less inhibition of the thalamus. The direct pathway is inhibiting an inhibitor, so the output from the thalamus is stronger, and you get facilitation of movement. So the direct pathway facilitates movement. The substantia nigra pars compacta sends signals to the striatum. These neurons produce dopamine, which acts on D1 receptors in the direct pathway. That is an excitatory signal, so the substantia nigra stimulates the direct pathway and facilitates movement. There's also an indirect pathway from the neostriatum to the internal globus pallidus that goes through 2 other sites: the external globus pallidus and the subthalamic nucleus. Let's go through these, working backward from the internal globus pallidus. The thalamus still sends its excitatory signal to the cortex, and the internal globus pallidus sends its inhibitory signal to the thalamus, which inhibits the thalamus. Remember, the internal globus pallidus inhibits movement. The subthalamic nucleus sends an excitatory signal to the internal globus pallidus. This stimulates the internal globus pallidus and inhibits movement further. The external globus pallidus sends an inhibitory signal to the subthalamic nucleus. This is disinhibitory overall because the signal from the subthalamic nucleus is weaker, which means the signal from the internal globus pallidus is weaker, so the excitatory signal from the thalamus is stronger and movement is facilitated. The striatum sends an inhibitory signal to the external globus pallidus. This is disinhibitory. It's like a double negative. If you inhibit the inhibitor of an inhibitor, the overall result is inhibition. The striatum inhibits the external globus pallidus, which increases the excitatory signal from the subthalamic nucleus and increases the inhibitory signal from the internal globus pallidus. This inhibits the signal from the thalamus. So the indirect pathway inhibits movement. The substantia nigra pars compacta sends signals to the striatum. Now remember, in the direct pathway, dopamine was acting on excitatory D1 receptors, so dopamine was facilitating movement. Well, in the indirect pathway, dopamine is acting on inhibitory D2 receptors. The transmitter is the same, but the receptor is different, and the results are different. Dopamine stimulates the direct pathway, but it inhibits the indirect pathway. Since the indirect pathway inhibits movement, dopamine, which inhibits the indirect pathway, facilitates movement. So whether we're looking at the direct pathway or the indirect pathway, dopaminergic signals from the substantia nigra to the neostriatum have the same result: more movement. And when you reduce dopamine production in the substantia nigra, you're going to have reduced movement. Now, the dopaminergic neurons from the substantia nigra fire tonically. They don't fire in response to specific stimuli or to trigger specific muscle movement. They exert a sustained tonic influence over movement in general. The striatum is also sending stimulatory cholinergic signals to areas in the striatum that produce GABA, and those GABAergic projections go back to the substantia nigra. So if you stimulate the striatum, you're going to inhibit further stimulation by the substantia nigra. In Parkinson's disease, you have loss of dopaminergic cells in the substantia nigra, and that leads to less inhibition of the neostriatum, and so you have more acetylcholine. So the symptoms of Parkinson's disease reflect an imbalance between the excitatory cholinergic neurons and a greatly diminished number of inhibitory dopaminergic neurons. The loss of inhibition of the indirect pathway is much more important in Parkinson's disease than the loss of stimulation of the direct pathway. And our therapies are aimed at restoring dopamine in the basal ganglia and antagonizing the excitatory effects of the cholinergic neurons.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
All right. I'm going to name a neurotransmitter, and you tell me whether it's excitatory or inhibitory. Norepinephrine. Excitatory. Acetylcholine. Excitatory. Glycine. Inhibitory. Dopamine. Inhibitory. GABA. Inhibitory. Serotonin. Excitatory. Glutamate. Excitatory. Substance P. Excitatory. Come on! You should know this in your sleep. It's all right there in black and white. Know it!
Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. It's time for your quick review number 1. Let's get started. What two neurotransmitters are primarily used in the ANS, or the autonomic nervous system? Well, this is different than the CNS, because the CNS uses a lot of the neurotransmitters that we have in our body. But for the autonomic nervous system, we use two primarily, and that's acetylcholine and norepinephrine. Next question. What effects do the neurotransmitters acetylcholine and GABA have when they bind to a receptor? Well, For acetylcholine, you're gonna see a cause of sodium channels to open, and this leads to depolarization of the neuron. In contrast to that, GABA causes a chloride channel to open, and this leads to hyperpolarization of the neuron. Next question. Describe the characteristic findings in the brain of a patient with Parkinson's disease. Well, there's several things. First is destruction of cells in the substantia nigra, reduced dopamine in the neostriatum, and increased acetylcholine. Next question. In the basal ganglia, which pathways facilitate movement and which pathways suppress movement? How does dopamine affect movement? Well, the direct pathway facilitates movement and the indirect pathway suppresses movement. And then more dopamine in the neostriatum leads to more movement. So remember, direct pathway facilitates, indirect suppresses, dopamine in the neostriatum leads to more movement. Next question. What mnemonic can you use to remember the cardinal features of Parkinson's disease? Well, we like to use TRAP. And sometimes you can imagine a Parkinson's patient feeling trapped in their body. So T, tremor, you're going to see that pill rolling tremor. Rigidity, people will have the cogwheel rigidity. Remember, it's not that they can't move at all, it's just they kind of move in that sort of cogwheel movement. Akinesia. So what is akinesia? Well, this is sort of a lack of movement. So one is they have a difficulty initiating movement. So you'll see someone standing there who has Parkinson's disease and you tell them, well, go walk to the other side of the room, and they'll sort of stand there and you could tell that their brain is going walk, 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 but their feet aren't moving. So they sort of sit there and they have a hard time starting. Another thing you'll see is that your Parkinson's disease patients will have falls, and you'll see this sort of, they'll lean forward and then they won't be able to get their legs moving, so they'll kind of get this shuffling thing and then they'll just sort of fall forward. The other thing with akinesia is flat affect. So you're going to see, especially your severe Parkinson's patients, just with this flat face. They're not going to be excited. You're going to think they're kind of mad at you because they're not smiling, they're not interacting with you, but it's just that that's their difficulty of initiating that affect. And the other one is for P, postural instability, and that's what we talked about before a little bit with the walking, but in general you're going to have some postural irregularities and falls do occur. Next question. What disorder results from a deficiency in the following neurotransmitter? So good stuff to know. So reduced norepinephrine and 5-HT, so this is serotonin. And that's going to lead to depression, which makes sense because we have a lot of medications that increase serotonin and increase norepinephrine for depression. Increased norepinephrine. So this is something that can cause mania and anxiety. And that makes sense because norepinephrine is excitatory. Dopamine deficiency. Well, we've been talking about this. Parkinson's disease, obviously. Dopamine excess, and we've talked about this briefly as well, and this can lead to schizophrenia or psychosis, so it worsens hallucinations. And then reduced acetylcholine, that's going to be your Alzheimer's disease and your Huntington's disease. Next question. Which neurotransmitter fits each of the following descriptions? So excitatory neurotransmitter at the neuromuscular junction, acetylcholine. Main inhibitory neurotransmitter of the brain, remember that's GABA. Main inhibitory neurotransmitter of the spinal cord, that's going to be glycine. Main excitatory neurotransmitter of the brain, and that's going to be glutamate. All right, so that's going to conclude our first quick review. Let's get back to the lecture.
All right, let's talk about the treatment of Parkinson's disease. So there are a lot of drugs that are available, and all these drugs temporarily relieve symptoms, but they don't reverse the neuronal generation. So there's a mnemonic for some of these drugs. The mnemonic is BALSA, B-A-L-S-A, like the balsa wood. This stands for bromocriptine, amantadine, levodopa, selegiline, and antimuscarinics. Now the real problem with this mnemonic is these aren't the most common drugs necessarily used for Parkinsonism. They're not in the correct order that you might use them for Parkinsonism. So I want to talk about these drugs, grouping them according to how they work, and talk about which drugs are more commonly used than others. So the first drugs we'll talk about in the treatment of Parkinsonism are levodopa and carbidopa. These are the first-line drugs. These are the mainstay drugs for the treatment of Parkinsonism. Now, levodopa is also known as L-dopa. If you are familiar with the movie Awakening, starring Robin Williams and Robert De Niro, they were treating patients with Parkinsonism using L-dopa. This was sort of the story of how this drug was discovered. Levodopa is a metabolic precursor to dopamine. Dopamine does not cross the blood-brain barrier. You can't give dopamine and expect it to be taken up into the brain and be active in the basal ganglia. But levodopa is actively taken up by the brain. It's taken up across the blood-brain barrier, taken up into the brain so it can be converted into dopamine in the CNS. And you have to use large doses of levodopa because a lot of the drug is metabolized peripherally in the GI tract and in the peripheral tissue, and this causes a lot of side effects. We'll talk about these side effects: nausea, vomiting, cardiac arrhythmias, hypotension. So you have to give large doses of levodopa to overcome this peripheral conversion to dopamine. But once it's taken up into the CNS, it's converted to dopamine, and this causes decreased rigidity, decreased tremors, basically a decrease in all of the symptoms of Parkinson's disease. Now, the other drug that we use with levodopa is carbidopa. Carbidopa is an inhibitor of the enzyme called dopa decarboxylase. Carbidopa does not cross the blood-brain barrier. So dopa decarboxylase is the enzyme that converts dopa to dopamine, and carbidopa is going to inhibit that, so you're going to have decreased metabolism of levodopa in the peripheral tissue, in the GI tract. So more levodopa is available to cross the blood-brain barrier and be taken up into the CNS, so you don't have to use as much levodopa to get the same effect in the basal ganglia. So you have fewer adverse effects from all that peripheral conversion of levodopa to dopamine when you use carbidopa. We use these two drugs together. The drugs are given in combination. The combination pill has the brand name Sinemet, so you'll see that a lot. Sinemet substantially reduces the severity of disease for the first few years of treatment in about 2/3 of patients who take it. But after 3 to 5 years, you start to see a decreased response to levodopa and carbidopa. The reason for this isn't entirely clear. It's possibly due to progressive loss of the nigrostriatal nerve terminals. It's possibly due to some pathological process involving the dopamine receptors themselves. Often we use drug holidays where we discontinue the drug for 3 days, a week, couple of weeks, up to 21 days, because these drug holidays can alleviate the side effects and temporarily improve responsiveness to the drug. But when you take the patient off the drug, you run the risk of immobility, which can cause other complications such as aspiration pneumonia, venous thrombosis, pulmonary embolism, depression, lots of problems when you are off the medication. There's also a phenomenon with levodopa and carbidopa called wearing off, where in early disease there's enough neurons around in the substantia nigra to convert the levodopa to dopamine, so the therapeutic response to levodopa is consistent and the drug effect doesn't really wear off. But with time, you have continued degeneration, you have continued cell destruction, and so there are fewer cells that are capable of taking up levodopa, and consequently, motor control will fluctuate. Even when you take the medicine, it may not work quite as well. So you can have some dyskinesia or difficulty with movement following the dose, and you can have akinesia or absent movement or lack of movement between doses. So the pharmacokinetics of levodopa and carbidopa, these drugs are absorbed rapidly from the small intestine when they're given without food, given on an empty stomach. High protein meals interfere with the transport of levodopa into the CNS because large neutral amino acids such as leucine and isoleucine compete with levodopa for absorption from the gut and for transport across the blood-brain barrier. So levodopa should be taken on an empty stomach, typically about 45 minutes before a meal. Levodopa and carbidopa have a short half-life of only 1 or 2 hours, and this can cause fluctuations in plasma concentration. You can have fluctuations in motor response that may be correlated with plasma concentration. You can also get something called the on-off phenomenon, where motor fluctuations are not related to the plasma levels in a very simple way. Motor fluctuations may cause sudden loss of normal mobility. You can get worsening of tremors, cramps, and just complete immobility that just happens all of a sudden. Withdrawal from the drug must be gradual for this reason. There are a lot of adverse effects and side effects involved with treatment with levodopa. Most of these are caused by the peripheral conversion of levodopa to dopamine. So in the cardiovascular system, dopamine can cause tachycardia. It can also cause arrhythmias, specifically ventricular extrasystole. Levodopa can also lead to some hypotension. Levodopa has an adrenergic action on the iris, so it can cause mydriasis or dilation of the pupil. The drug can cause an increase in intraocular pressure, so you need to be careful in patients with glaucoma. Levodopa can cause blood dyscrasias. It can cause a positive reaction on the Coombs test occasionally. It will also cause a patient's saliva and urine to turn brown because of melanin pigment that's produced from catecholamine oxidation. Levodopa can also cause a lot of CNS effects. It can cause visual and auditory hallucinations. It can cause dyskinesias or movement problems, sort of the opposite of Parkinsonism, where you have more movement than you want to. Levodopa can cause mood changes and depression, also psychosis and anxiety. Levodopa will also stimulate the chemoreceptor trigger zone of the medulla and cause anorexia, nausea, and vomiting. There are a lot of drug interactions to be aware of with levodopa. Antipsychotic drugs are generally contraindicated in Parkinson's patients, as we mentioned, because these block dopamine receptors and produce a Parkinsonian syndrome. Low doses of some atypical antipsychotic drugs are sometimes used to treat the levodopa-induced psychiatric symptoms. So it's kind of weird we're using a dopamine agonist to treat the Parkinsonism, and that's causing the psychiatric symptoms. As I mentioned, increased dopamine can cause certain psychiatric problems. And then you give an antipsychotic drug to block the dopamine and treat those symptoms. Other drug interactions include pyridoxine or vitamin B6, which increases peripheral breakdown of levodopa. So the levodopa is going to be less effective if it's taken with vitamin B6. And then monoamine oxidase inhibitors such as phenelzine can produce a hypertensive crisis caused by enhanced catecholamine production. So there are lots of other drugs that we use to treat Parkinsonism. And we'll talk about two groups of these, drugs that inhibit dopamine and levodopa metabolism. So there's two basic classes here, the monoamine oxidase inhibitors and the COMT inhibitors. First, we'll talk about the monoamine oxidase inhibitors, selegiline and rasagiline. Selegiline at low to moderate doses selectively inhibits monoamine oxidase B, which is the enzyme that metabolizes dopamine. At higher doses, it also inhibits monoamine oxidase A, which is the enzyme that metabolizes norepinephrine and serotonin. And because you're inhibiting the breakdown of dopamine, the metabolism of dopamine, you're going to have increased dopamine levels in the brain. Selegiline enhances the action of levodopa when they're given together, and it reduces the amount of levodopa that you have to give. So kind of like carbidopa, if you're allowing levodopa and therefore dopamine to stay around longer, you're going to not have to give as much levodopa, so you don't have as many side effects from levodopa. The adverse effects, though, unlike the non-selective MAOIs, there's less potential for causing hypertensive crisis with selegiline. Unfortunately, selegiline is metabolized to methamphetamine and amphetamine, and this can lead to insomnia. Now, rasagiline is another MAOI that's an irreversible selective MAO-B inhibitor. So it's 14 times more selective for MAO-B than it is for MAO-A, and it has 5 times the potency of selegiline. Rasagiline is metabolized by cytochrome P450 1A2, and it's not metabolized to an amphetamine-like substance as selegiline is, so it doesn't cause the insomnia. Now we'll talk about another group of drugs, the COMT inhibitors, or catechol-O-methyltransferase inhibitors. These drugs include entacapone and tolcapone, and that always makes me think about Al Capone, but he was a different kind of inhibitor. So the mechanism of action of COMT inhibitors, COMT is the enzyme that methylates levodopa to a chemical called 3-O-methyldopa. Now normally this is a minor pathway for the metabolism of levodopa. What's the main pathway for metabolism of levodopa? Well, it's converted to dopamine, and that's what we want. So when you use carbidopa, dopamine decarboxylase activity is inhibited, and you have more 3-O-methyldopa that's formed. So by giving a COMT inhibitor, you're going to reduce that production of 3-O-methyldopa. Because 3-O-methyldopa competes with levodopa for active transport into the CNS. So if we can decrease concentrations of 3-O-methyldopa, you have increased CNS uptake of levodopa, you have increased CNS production of dopamine, and you can reduce the wearing off phenomenon that's seen on patients who are taking levodopa and carbidopa. In terms of pharmacokinetics of COMT inhibitors, The absorption of these drugs is not influenced by food, unlike levodopa. These drugs are extensively bound to albumin. Entacapone inhibits peripheral COMT. It does not act in the CNS. It therefore requires more frequent dosing than tolcapone. Tolcapone can cross the blood-brain barrier, but its main action is peripheral. It has a relatively long duration of action, probably due to a very high affinity for the enzyme. And both drugs are extensively hepatically metabolized, so you have to adjust the dose in patients who have moderate or severe cirrhosis. And both drugs are eliminated in the feces and in urine. The adverse effects of COMT inhibitors are very similar to the adverse effects we saw with levodopa and carbidopa. They can cause postural hypotension, they can cause nausea, anorexia, diarrhea, they can cause dyskinesias and hallucinations and sleep disorders, all related to increased dopamine. Tolcapone is also associated with a condition called fulminant hepatic necrosis, so it should only be used in patients in whom all other treatment options have failed, and you still have to monitor LFTs to make sure you're not having any hepatic damage. Entacapone does not show this toxicity, so it's largely replaced the use of tolcapone. So we're going to go out of order from Lippincott's for just a moment and talk about one more drug that actually increases dopamine levels. That drug is amantadine. So amantadine, as you may know, is an antiviral drug. We used to use it to treat influenza. We no longer use it for influenza because most influenza viruses are resistant to amantadine. But it was accidentally discovered that amantadine has some anti-Parkinsonian actions. There are several effects on a number of different neurotransmitters that are implicated in Parkinsonism. Amantadine increases dopamine release. It blocks cholinergic receptors. It also inhibits NMDA-type glutamate receptor. NMDA stands for N-methyl-D-aspartate, and we'll talk about those receptors in just a moment. This inhibition of the NMDA receptor is thought to be the primary action at therapeutic concentrations of amantadine. Now, amantadine is less effective than levodopa. Tolerance develops much more readily. It develops within about 6 weeks on amantadine. But amantadine has far fewer side effects, so it's a little safer. If dopamine release is already maximized, and amantadine is not really going to have any effect, because again, amantadine is increasing dopamine as one of its methods of action. Amantadine has very little effect on tremor. It has much more effect on rigidity and bradykinesia than the anticholinergic drugs, which we'll talk about shortly. In terms of pharmacokinetics, amantadine has a very short half-life of 2 to 4 hours, and most of the drug is excreted unchanged in the urine. Adverse effects for amantadine: it can cause restlessness, agitation, irritability, confusion, and hallucinations. It can also cause an acute toxic psychosis at high doses. It can cause some peripheral edema, some orthostatic hypotension. It can cause urinary retention and dry mouth. It can cause a lace-like purplish discoloration in the legs, which we call livedo reticularis. And you have to use amantadine with caution in patients who have a history of seizures or heart failure. Now we're going to backtrack a little bit and talk about some drugs that do not affect dopamine levels. These are the dopamine agonists and the antimuscarinics. The dopamine receptor agonists include bromocriptine, pramipexole, ropinirole, rotigotine, and apomorphine. We'll talk about each one of these on its own. Speaking first of bromocriptine, this is a dopamine receptor agonist. It's going to bind to the dopamine receptor and act just like dopamine at that receptor. So it has a longer duration of action than levodopa, so it can be effective when a patient is having a fluctuating response to levodopa, which we talked about. There's less risk of dyskinesias and motor fluctuations when you first start treatment. Unfortunately, it's ineffective in patients who have shown no response to levodopa. Bromocriptine can also be used to treat pituitary tumors. You'll remember that dopamine is involved in the regulation of secretion of pituitary hormone. So if you give a dopamine agonist, you can actually suppress pituitary tumor growth. In terms of adverse effects, unfortunately, bromocriptine has a lot of adverse effects, and the side effects severely limit the usefulness of these dopamine agonists in general. The drug can cause hallucinations, confusion, delirium, nausea, orthostatic hypotension, much more commonly than with levodopa, but you have less dyskinesia. Bromocriptine can cause mental illness to worsen, and psychosis is associated with excessive dopamine, as we mentioned a couple of times before. Bromocriptine can cause serious cardiac problems, particularly in patients with a history of MI. It can cause worsening of vasospasm in patients with peripheral vascular disease, and it can cause worsening of peptic ulcer in patients who have ulcer history. The next two drugs are pramipexole and ropinirole. These are also agonists of the dopamine receptors. They're usually used as monotherapy in mild disease because they may delay the need for levodopa. In advanced Parkinsonism, they may decrease the dose of levodopa that's required. And these drugs are also used to treat restless leg syndrome. In terms of pharmacokinetics, pramipexole is not metabolized. It's dependent on renal function for its elimination. So in a patient with renal insufficiency, you may be able to adjust the dose of pramipexole. Ropinirole is extensively metabolized by cytochrome P450-1A2. And what other drug did we mention just a moment ago that was metabolized by the same enzyme? Rasagiline. In terms of adverse effects, these drugs can cause hallucinations, insomnia, dizziness, nausea, constipation, orthostatic hypotension. Unlike bromocriptine, these drugs do not exacerbate peripheral vasospasm. And as we mentioned with bromocriptine, dyskinesias are much less frequent adverse effects than you see with levodopa. Another dopamine agonist is called rotigotine. It's used primarily in early Parkinson's disease. It's given as a once-daily transdermal patch that delivers the drug evenly over 24 hours. This is a relatively new drug. It was first approved in 2007, then it was off the market in 2008, and it's back on the market for restless leg syndrome. And then the last dopamine agonist is apomorphine. This is an injectable dopamine agonist that's used for the acute management of the hypomobility or OFF phenomenon. It causes some significant adverse effects, including significant nausea. It can also cause dyskinesias, drowsiness, some chest pain, some hypotension, and some sweating. We'll talk about one more class of drugs used to treat Parkinsonism, and these are the antimuscarinic agents. So these include benztropine. There's a mnemonic, park your Benz, like park your Mercedes-Benz. You can remember that benztropine is used for Parkinson's disease. There's a drug, trihexyphenidyl, procyclidine, and biparidine. So all these drugs block cholinergic transmission, and again, they're restoring the balance of acetylcholine to dopamine. These drugs are generally much less effective than levodopa. They're only used as adjuvants, and individual patients may respond more favorably to one drug than they do to another. The adverse effects of these antimuscarinic agents are similar to those adverse effects we see with high doses of atropine. So you can be blind as a bat, or you get pupillary dilation and cycloplegia. You're hot as a hair, which means increased body temperature. Dry as a bone, absence of sweating and secretions. Red as a beet, peripheral vasodilation and flushing. Mad as a hatter, you can get confusion and hallucinations. Bloated as a toad, you can get constipation and urinary retention. And then also tachycardia. You can also get visual problems, so these drugs are contraindicated in patients who have glaucoma, and in general they're contraindicated in patients with prostatic hyperplasia. We said that phenothiazines and haloperidol and other drugs can cause Parkinsonism, so how do we treat this drug-induced Parkinsonism? We don't just put these patients on carbidopa, levodopa. We often treat with benztropine, which is again one of those antimuscarinic drugs. We'll treat with diphenhydramine, which is the generic version of Benadryl. We'll also treat with a benzodiazepine, which you may know as Xanax or Valium. These are anxiolytic drugs, or you can also treat with a beta blocker. And then finally, there are some non-pharmacological treatments for Parkinson's disease that we'll talk about. These are rarely used anymore. These are surgical treatments. They're very invasive, obviously, but we'll talk about them briefly so you've at least been exposed to them. The first of these is called a pallidotomy. This is when you place an electrode in the internal globus pallidus, and then you heat that electrode up to create a lesion, so you have less inhibition of movement. This is not really done much anymore. It's much more common to do something called deep brain stimulation, where you place an electrical stimulator or a pacemaker to stimulate either the internal globus pallidus or the subthalamic nucleus. Basically, you're overstimulating these areas until they don't work anymore, so you have less inhibition of movement.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide.
Let's get back to the game. The sooner we do, the sooner it's over. Oh, come on, man. I'm the bomb diggity, yo. Woo, woo.
Next question is for $2,000. Questions do get hotter, so let's see if we can wipe that smile off your face.
You can try.
Which dopamine agonist depends on renal function for its elimination? A, pramipexole. B, apomorphine. C, ropenetrol. Or D, rotigotine.
Oh, man. These are getting tough. Can I use another lifeline?
No. You are lazy, unmotivated, and unimpressive. And also, I think I've made it very clear, stupid. So, for the sake of our poor viewers, you no longer get any hints, lifelines, or help of any kind.
Dude, that's cold.
Dude, just answer the question. Which dopamine agonist depends on renal function for its elimination?
Apomorphine?
No, I'm sorry. The answer was pramipexole. Pramipexole is renally clear, but apomorphine, ropenetrol, and rotigotine are hepatically cleared. Well, I hate to see you go. No, wait. I don't hate to see you go. That's all the time we have for today, so keep up your studies or you'll end up a sad, pathetic loser. Join us next time for Who Wants to Be a Gunner?
All right, we're back and it's time for quick review number 2. Let's get started. Why must levodopa be given in large doses, and how can you reduce the dose? Well, in regards to levodopa, most of the drug is metabolized peripherally in the GI tract and in the peripheral tissue. So initially we used large doses just to overcome that peripheral conversion. Now, what can you do in conjunction with that levodopa? Well, you can add carbidopa. Now, carbidopa does not cross the blood-brain barrier, and it diminishes the metabolism of levodopa in the GI tract and in the peripheral tissues. So this increases the availability of levodopa to the central nervous system and reduces the side effects. Now, selegiline can also be used, but far and away more often you're going to see that combination levodopa with carbidopa as your primary treatment. Next question. What medication causes brown urine and saliva as an adverse effect? So this one's pretty easy. This is levodopa. Remember, brown urine, brown saliva. Next, what effects occur when MAO inhibitors or pyridoxine are given with levodopa? So we don't see a lot of MAO inhibitors used anymore, but it could potentially happen. So what happens when you have an MAO inhibitor? Well, it produces a hypertensive crisis, and this is due to increased catecholamines. MAO will increase norepinephrine, dopamine, serotonin, a whole lot of things. So you got to be careful with a lot of different drugs and a lot of different foods with MAO inhibitors. Now, pyridoxine will increase the peripheral breakdown of levodopa, and it will diminish its effectiveness. So it's basically just breaking down that levodopa a little more efficiently. Next question. What are the advantages of adding a COMT inhibitor to levodopa? So this will leads to decreased plasma concentrations of the 3-O-methyl-dopa, and this increased central uptake of levodopa. So you get a greater concentration of dopamine in the brain. Next question. What enzymes degrade the dopamine and norepinephrine that remain in the synaptic cleft? So first we have COMT, we just talked about those inhibitors, and then MAO. So those two are our primary enzymes that are breaking down dopamine and norepinephrine. You also see MAO also intraneuronally as well, breaking things down. Next question. What would happen if a person on an MAO-B inhibitor ingested wine, aged cheese, or other tyramine-rich foods? Well, trick question. Nothing's going to happen. So it's your MAO-A inhibitors used in the treatment of depression that will cause major problems. The MAO-B inhibitors affect dopamine levels rather than epinephrine and norepinephrine levels, and therefore you won't get that hypertensive crisis. So tyramine, you'll get sort of this dumping phenomena where all the stored catecholamines just get released when you eat tyramine-rich food. So anything that's aged you have to avoid. But in this situation, MAO-B inhibitors, it's not the same scenario. Next question. When would you choose to give a COMT inhibitor to a patient? So we talked about we use levodopa, carbidopa a whole lot more than any other combination of meds. So when are we going to use these COMT inhibitors? Well, if after a few years after taking your levodopa and your carbidopa, if you start to get this wearing off, they're starting to get more symptoms, maybe you've increased the carbidopa-levodopa combo once, and you're getting kind of worried that you're not getting the effectiveness that you want, you can add on that COMT inhibitor. Next question. What are the side effects of the COMT inhibitors? Well, basically it's the same as levodopa, so you can get diarrhea, postural hypotension, nausea, anorexia, dyskinesias, hallucinations, and sleep disorders. All right, so that's going to conclude our quick review number 2. Let's get back to the lecture.
So let's talk next about Alzheimer's disease and the various treatments for Alzheimer's disease. Now, you're probably very familiar with Alzheimer's disease, or at least somewhat familiar with the constellation of symptoms. You get dementia, memory loss, personality changes, behavior changes. The cause of Alzheimer's disease is not entirely understood. There's definitely some loss of cortical neurons, particularly acetylcholinergic neurons. You have accumulation of senile plaques, which are made up of beta amyloid. You have the formation of what we call neurofibrillary tangles, which are made of tau protein. And really, the treatments we have for Alzheimer's are only palliative. They only provide some modest short-term benefit. None of the currently available drugs really alter the underlying neurodegenerative process. I usually tell patients when I'm starting them on this drug, I tell the patient or I tell the patient's family, I can't help your memory come back. I can't improve memory that's already been lost. But hopefully with the medication we can slow down the memory loss. We can prevent it from getting much worse, or we can make it get much worse much more slowly. Remember that Alzheimer's disease is very progressive and that patients will eventually get to the point where they cannot interact with family members, they can't feed themselves, they can't dress themselves. So this is a very debilitating disease, and if we can delay that progression to the point where they don't have to wind up with 24-hour care at a nursing home as early as they would without the drug, we're definitely doing them some benefit, even though we're not curing the disease or reversing the memory loss. So the current therapies for Alzheimer's disease are either aimed at improving cholinergic neurotransmission in the CNS or preventing overstimulation of the NMDA receptors that we talked about earlier. So first we'll talk about acetylcholinesterase inhibitors. These are drugs like donepezil, galantamine, rivastigmine, and tacrine. All these work by the same mechanism. Remember we talked about progressive loss of cortical cholinergic neurons that's associated with memory loss. So in theory, if you inhibit acetylcholinesterase, you can improve cholinergic transmission in the neurons that are still around, the neurons that are still functioning. So all these drugs we just mentioned are non-competitive inhibitors of acetylcholinesterase, except for galantamine, which is a competitive inhibitor of acetylcholinesterase. These drugs are more active in the CNS than they are peripherally. They're lipophilic, so they cross the blood-brain barrier. Unlike the acetylcholinesterase inhibitors that we saw in the treatment of myasthenia gravis, such as neostigmine, those act just peripherally. These drugs we're talking about today are lipophilic. They're going to cross the blood-brain barrier and act in the CNS. They do cause a modest reduction in the rate of loss of cognitive function in patients with Alzheimer's disease. In terms of pharmacokinetics, these drugs are extensively metabolized by cytochrome P450, and there's a lot of potential drug interactions, except for rivastigmine, which is not metabolized by cytochrome P450. Adverse effects include nausea, diarrhea, vomiting, and anorexia, and these GI side effects may really limit tolerability. You put a patient on the drug, and you bring them back in a month and ask the family, how's the patient doing? Can you see any improvement in behavior, any improvement in cognition? And they say, well, we can't really see much improvement, but now the patient is not eating, she's vomiting, she's having a lot of GI problems. That's going to limit the usefulness of these drugs. These drugs can also cause tremor, they can cause bradycardia, they can cause muscle cramps, and tacrine is associated with hepatotoxicity, so it's not widely used anymore. The other three are still widely used and are generally considered first-line drugs for the treatment of Alzheimer's disease. Now, the other drug we'll talk about is an NMDA receptor antagonist, and that's the drug memantine. So stimulation of glutamate receptors in the CNS appears to be critical to the formation of certain memories. But overstimulation of these glutamate receptors, particularly the NMDA-type glutamate receptor, is shown to result in excitotoxic effects on neurons, and this may be a mechanism of neurodegenerative disease. So the NMDA glutamate receptor opens an ion channel and allows sodium in and allows calcium to enter the neuron. And it's this excessive intracellular calcium that ultimately leads to damage to the neurons and apoptosis. So the mechanism of action of memantine. Memantine blocks a portion of the NMDA glutamate receptors, the ion channels. So it actually gets in there and blocks a fraction of those ion channels. In contrast, phencyclidine, or PCP, the illicit drug, basically blocks all of the NMDA-type glutamate channels. So memantine slows the rate of memory loss in patients with moderate to severe Alzheimer's disease. There's no real evidence that it prevents or slows down the neurodegeneration, but it can slow down the symptoms, the memory loss. And there's no evidence that memantine is any more effective than an acetylcholinesterase inhibitor. The memantine is often given in combination with the cholinesterase inhibitor, and unfortunately there's no real long-term data that this combination is more effective than either drug by itself. The adverse effects of memantine include confusion, agitation, restlessness. Now these effects are pretty much indistinguishable from some of the symptoms of Alzheimer's disease, so it's sometimes hard to tell, is the patient's disease getting worse or are they having an adverse effect from the drug? The drug can also cause dizziness and hallucinations. It's also worth noting that memantine can be metabolized differently by different patients. The standard dose of memantine, you start out with 5 milligrams once a day, and then you increase to 5 milligrams twice a day, and you gradually increase that up to 10 milligrams twice a day. And when you give the drug, you give a sample, they will have a card, and it's written out exactly what to take, and they just punch out the drug and take it. And so you give the patient the drug and say, start taking this and come back in a month and we'll talk about how well it's working. Well, very often you'll have patients who come back after a month and they say, no, I'm not still taking the drug. I'm having way too many side effects from it. It may be that that person is just metabolizing the drug more slowly than the typical person does. So you may be able to tolerate that drug if you stay with that 5 milligram dose once a day for a longer period of time. You may get some benefit from that even though you're not at the typical dose. And finally, we'll mention one other NMDA receptor antagonist called riluzole, which is used to treat amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. This drug prevents excitotoxicity just like memantine did, and it may improve survival time and delay the need for ventilator support in patients with ALS. The adverse effects of riluzole unfortunately include nausea, fatigue, and hepatotoxicity.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide. All right, we're back and it's time for quick review number 3. Let's get started. What histologic or gross findings will you see in a patient with Alzheimer's disease? So you're going to see widespread cortical atrophy. You're going to see decrease in acetylcholine, senile plaques. That's an important one you'll see on tests. You'll see neurofibrillary tangles. Remember those tangles? And these are the intracellular abnormal phosphorylated tau proteins. And the tangles correlate with the degree of dementia. So you're going to get more tangles with more dementia. Next, what are some characteristics of acetylcholinesterase inhibitors? These things are inhibiting the inhibitors, so they're stopping that breakdown of acetylcholine in that synaptic cleft. So you're going to get improved cholinergic transmission for functioning neurons. So if the acetylcholinesterases can't slice up your acetylcholine, then you're going to have more acetylcholine available. Now, they can cross the blood-brain barrier because they are lipophilic, and then they will act in the CNS. Next question. What allele is associated with Alzheimer's disease? Why is Alzheimer's so common in patients with Down syndrome? So we didn't mention anything about this in the lecture, but good to know. But Alzheimer's is associated with APP21 and APOE4. So try to remember that. You might get a test question on that. in regards to the Down syndrome, it's more common in patients with Down syndrome because the APP gene is on chromosome 21. So now you have 3 copies potentially having that APP 21. Next question. Which neurodegenerative disease matches the following statements? So our choices are Parkinson's disease, Alzheimer's disease, ALS, or Huntington's disease. So senile plaques, neurofibrillary tangles, easy, Alzheimer's disease. Lou Gehrig's disease, he's a famous New York Yankee baseball player, and that's why we know ALS in regards to that. In other countries, they may not call it Lou Gehrig's disease, they'll probably know it more as ALS. Atrophy of caudate nucleus leading to chorea, that's going to be Huntington's disease. Depigmentation of substantia nigra, that's Parkinson's disease. Both upper and lower motor neuron signs, so spasticity and weakness, that's going to be ALS. Lewy bodies, that's going to be Parkinson's disease. And then decrease in acetylcholine, Alzheimer's disease, and Huntington's disease. Next, what are the primary characteristics of amyotrophic lateral sclerosis, or ALS? I just want to give you a few more details about this. So it's a neurodegenerative disease that affects both upper and lower motor neurons. That's an important distinction there that you might get on a test. Degeneration of neurons located in the ventral horn of the spinal cord and the cortical neurons that provide their afferent input. Symptoms will include rapidly progressive weakness, muscle atrophy, fasciculations, spasticity, dysarthria, dysphagia, and respiratory compromise. So it's a rapid problem, and then most patients die of respiratory compromise and pneumonia within 2 to 3 years. So really, really sad if you get diagnosed with this. It's just a progressive weakness over time. Now, in most cases, patients will maintain their cognition, so they'll be pretty aware of what's going on. Occasionally you can get some dementia with it, but most of the time also they'll have control over eye movements, but it's the respiratory compromise that eventually will kill them. All right, so that's going to conclude our quick review number 3. The next part will be our end of session quiz. So I want you to stop the video. I want you to try to answer all the questions in the end of session quiz, and then restart the video, and then we'll go over the answers together. All right, it's time for our end of session quiz. Let's get started. What disorder results from abnormal levels of the following neurotransmitters? Well, first we have reduced norepinephrine and serotonin. We've talked about these before. This will lead to depression. Increased norepinephrine. This can lead to mania or anxiety. Dopamine deficiency, easy, Parkinson's. Dopamine excess, schizophrenia. Reduced cortical acetylcholine, Alzheimer's disease. Next question. What steps are involved in the synthesis of catecholamines such as norepinephrine? So this is a great little thing to learn because you'll see sort of the interrelatedness of a lot of these neurotransmitters. So first we start off with phenylalanine, and this will then be transformed into tyrosine. The next step is that it'll become L-dopa, and then finally dopamine. Now from dopamine, it goes to norepinephrine, and then norepinephrine gets transferred into epinephrine. So realize that dopamine and norepinephrine and epinephrine are very closely related to each other. Next question. What neurotransmitter fits the following description? So excitatory neurotransmitter at the neuromuscular junction, that's going to be acetylcholine. Main inhibitory neurotransmitter of the brain, GABA. Main inhibitory neurotransmitter of the spinal cord, glycine. Next, main excitatory neurotransmitter of the brain, that's going to be glutamate. Now we've gone over that twice now, so you should know all those neurotransmitters. Next question. What drugs can induce symptoms of Parkinson's disease? So we do have several drugs that can induce a lot of these symptoms, so be aware of them. So the phenothiazines, they're categorized as antipsychotics, but they're often used as antiemetics as well. So chlorpromazine is one of them, and then promethazine. Promethazine is used all the time in the inpatient and outpatient setting for nausea. The atypical antipsychotic drugs, and haloperidol, certainly can cause Parkinson's disease. And then also another one that you wouldn't think would cause it is metoclopramide. So another medicine that we use for nausea and vomiting or some gastroparesis can certainly cause Parkinson's symptoms. Next question. Name the therapeutic uses of the following drug. So amantadine. So we use this in early or mid Parkinson's disease. What other problem was it used for in the past? It was used for influenza A, but now there's so many resistances, we don't use it very often. Galantamine, we use this for Alzheimer's disease, and Riluzole is used for ALS. Next question. Which COMT inhibitors are used in the treatment of Parkinson's disease? So, well, we have two of them. We have entacapone and we have tolcapone. Now, tolcapone we don't use very often because it has an increased risk of fulminant hepatic necrosis. All right, next question. Match the following clinical descriptions with the most appropriate therapeutic agent. So we have rivastigmine, benztropine, amantadine, and rotigotine. So the first one here, a 68-year-old man with early Parkinson's disease who cannot remember to consistently take his medications. So rotigotine would be the one because it comes in a transdermal patch. So it has a much more simple administration. A 64-year-old man with Alzheimer's disease on multiple drugs that induce P450, so cytochrome P450. So the rivastigmine would be a good one because it's the only anti-acetylcholinesterase inhibitor that does not metabolize the cytochrome P450. Next, an 83-year-old woman with Parkinson's disease has a lot of rigidity and bradykinesia and cannot tolerate levodopa, so that's not a very good situation actually. Amantadine, now it won't help the tremor, but it can help with rigidity and the bradykinesia, so that could be a good option for her. A 78-year-old woman is on levodopa and needs an adjuvant agent for Parkinson's disease. This could be several different things, but in our list of medications here, probably benztropine would be the best one. Our next question, match the adverse effect to the Parkinson's disease therapy. So the first one, brown urine saliva, that's easy, that's levodopa. Constipation and urinary retention, this is our anticholinergic effect, so bloated as a toad is our way of remembering the urinary retention and constipation. So the only antimuscarinic drug on this list is benztropine. Fulminant hepatic necrosis, so we talked about this just a second ago, that's the tolcapone. Levato reticularis, that's going to go with amantadine. Positive Coombs test, that's going to be levodopa. Vasospasm in patients with peripheral vascular disease, that's going to be bromocriptine. Blood dyscrasias, levodopa. Hypertensive crisis, and this is usually at high doses, this is selegiline. Next, match the drug classes below with the disease they treat. So acetylcholinesterase inhibitors are going to treat B, Alzheimer's disease. Antimuscarinic agents, A, Parkinson's. COMT inhibitors, A, Parkinson's. Dopamine receptor agonists, again Parkinson's. MAO-B inhibitors, Parkinson's. And then the NMDA receptor antagonists, that's going to be Alzheimer's disease and ALS. Next, what are the contraindications to the use of antimuscarinic agents? Now these are very, very common medications. A lot of them are over the counter, but things you need to avoid, people who have glaucoma, BPH or any urinary retention, because that can certainly make urinary retention worse. Ileus or bowel obstructions, same sort of deal. That bloated as a toad, you don't want to make those toads more bloated. Elderly patients, sometimes we forget that antimuscarinics can cause delirium, and in elderly patients, it can certainly happen. Patients with delirium in general, so if you have someone who has some other psychiatric disorder or other problems, you don't want to give them antimuscarinic agents. And then infants, in general, you don't want to use it too often, but infants with a fever, you want to use it even less. All right, so that's going to conclude our end of session quiz, and that's going to be the end of our lecture. I hope you learned something.